All right, good morning, everyone. We are going to get started. Good to see everybody here. I want to introduce our speaker today, Dr. Lipman, who's a clinical associate professor at ETSU, Department of Psychiatry and Behavioral Sciences. He's a neuropharmacologist who serves as a forensic consultant, an expert witness in neuropharmacology, neurotoxicology, and idiosyncratic effects of drugs and their interactions on human behavior. So without further ado, I'll hand it over to Dr. Lipman.
Sort of. Is it working now? Okay. I've been told that the laser pointer is not working, and the slide advance is not working. So I am yoked to this keyboard. So some people may not be able to see me. I am the head above this screen. Sorry about that. Oh, I'm still yoked to the keyboard. The subject of today's talk was one that was suggested actually by Tom Schacht. I would not have chosen it. It's a huge field, and to condense some of its important elements into 1 hour is a bit of a challenge, so I think you might forgive me if I don't cover the area that you are interested in. I do not have anything to declare, and I actually don't know what is approved or unapproved, but if I do talk about something that's unapproved, forgive me. So really the question I think that I wanted to have you asking is, what can a prescriber learn from a genotype analysis? Now, obviously, the first thing that comes into everyone's mind is that you can learn about the activity of drug metabolizing enzymes, such as the phase 1 enzymes, the P450s, but that is actually not, that's just the tip of the iceberg of the field of pharmacogenetics. But I will be addressing that. Perhaps even more importantly is the autopharmacology of the underlying systems. Independent of whether the person is getting a drug or not, the activity of the neurotransmitter carriers, the dopamine transporter, the serotonin transporter, and norepinephrine and permeability glycoprotein are all under genetic control, and different people have different activities in these enzymes. This really is the basis of, one of the bases of what in future we'll be calling personalized medicine. I function as a forensic neuropharmacologist much of the time, and a very common question for me is, someone has had a catastrophic reaction to a drug. I come in after the fact, usually appointed by the court or an insurance company or a bereaved, and I see what has gone wrong, and I find that the person suffered a catastrophic reaction because he was vulnerable to it. The prescriber may say, but how would I know that? That incidence is 1 in 1,000 people. And yes, this is the 1 in the 1,000 people. Pharmacogenetics can help identify that. The sensitivity of drug targets is another piece of information that we get from genotype analysis. These are the receptors and the transporters, and the activity of the neurotransmitter control enzymes. In psychiatry, you're dealing mostly with catechol O-methyltransferase and monoamine oxidase, but these are all identified. Their genotypes differ from one individual to another as to how effective they are, and these are something that come from a genotype analysis. In addition, and this relates to the underlying psychological, psychiatric disorder from which the person suffers, which the psychiatrist or the prescriber is going to be prescribing for, is that the genotype of the individual and its modification in its activity, which is the phenotype, is subject to environmental modification. And this can include induction and inhibition of the enzymes involved, epigenetic methylation, which is a permanent switch, usually in the regulator region, and suppression of the gene. And perhaps most importantly for us, the environment includes chronic endocrine stress and toxicity, injury, metabolic, other disease, and chronic drug treatment, which can have been historic, that causes enduring changes in the phenotype. The scope of the present genotype analyses that pharmacologists use covers 17 psychopharmacologically relevant genes. The dopamine receptors, serotonin receptors, the monoamine transporters coded on chromosomes 16, 5, and 17 for norepinephrine, dopamine, and serotonin, and the degradative enzymes, catechol-methyltransferases on 22. Monoamine oxidase A is on the X chromosome, and of course that's been associated with misbehaviors that you would call constitutional. The cytochrome P450 enzymes coded throughout the system, and permeability glycoprotein, which is a very important drug carrier that is responsible for excreting, for pulling drugs out of the brain, and is largely responsible for what we call the blood-brain barrier. These are some of the things that I will hope to cover, but to begin, so that everyone's on the same page, I would like to begin with some very simple terms, and then we'll move on to how these components work. DNA is composed of base pairs. The bases are adenine, guanine, thymine, and cytosine. And when the DNA is transcribed into RNA, uracil replaces thymine. The smallest piece of genetic information is the triplet codon that is made up of 3 base pairs. The triplet codon is like a letter in the alphabet of the protein that will be formed. The variability that we find that genetic testing reveals is the single nucleotide polymorphism. This is usually abbreviated to SNP, and it's a DNA sequence variation that occurs when a single nucleotide, in this case A, T, or C, is transposed, and there is a substitution. These things happen randomly, and once they've happened, they're fixed for life. In this case, the transposition is from a C to a T, cytosine to thymine, and in this case, the codon, which was coding for leucine, will continue to code for leucine, because this is what's called a synonymous transposition, or a synonymous SMP. Now, that's an example actually of an exception, but it's one that makes the explanation quite easy, because when you look at the gene variations, that single nucleotide polymorphisms, which should properly be called substitutions, certain amino acids have absolutely no tolerance for a substitution. For instance, methionine is ATG. If either the A or the T or the G gets substituted, it isn't methionine anymore. And that's a very important amino acid codon because it acts as the start sequence in the reading of the gene. Others, such as arginine, it almost doesn't matter what you do to substitute arginine. It's always going to code for an arginine amino acid. But there is different degrees of tolerance for variation of DNA codon identity with the different amino acids. Tryptophan is another very unforgiving code. Any change, any single nucleotide polymorphism or substitution in that codon produces something that isn't tryptophan. And of course, those have profound consequences. To continue the nomenclature, to give you a basic grounding in understanding, I have put up here chromosome 1. Could be any chromosome, but the nomenclature that we can get from this, the center of the chromosome where the two halves of the chromatids are attached is called the centromere. At the end, each end of the chromatids is a string of code called the telomere. Very important, but I'll refer questions on that to Dr. Ordway, who's sitting in the audience. There is always a smaller arm and a longer arm. The smaller arm of the chromosome is called the P arm. It comes from the French, petite. Does anyone know why the other arm is called a Q arm? No? I have never found out why it's called a Q arm. I don't think anyone knows. I was hoping. In the nomenclature of a gene, this is a gene. In the nomenclature of a gene, the first digit is the number of the chromosome. The next element is whether it's on the P or the Q arm, and the next numbers are the base position. So for instance, I said that I don't know that chromosome 1 is particularly important from a pharmacological point of view, but it does have the ASPM gene on the Q arm in band 31, so that would be labeled as 1Q31.1, and the ASPM gene is responsible for brain size, so it's got to be important. The gene itself, this is an example of a representative gene, is composed of a promoter region which determines how the gene itself is read. It has a start sequence which begins the reading of the gene according to the instructions of the promoter region, and it has interspersed what are called introns and exons. Only the exons code for actual protein, but the introns are transcribed, they produce RNA, and they control what exons are read. So there is no dead or unused DNA here. It does something, all of it. The gene is read from the 5' end to the 3' end, which we represent as left to right. I don't know how Arabs or Israelis do it, but we always represent it as the 5' end to the 3' end. The gene on a chromosome is, of course, whatever that gene is one of two, because we are diploid creatures. And these two genes, both coding for the same functionality, are called alleles. So when we talk about the gene for instance, cytochrome P452D6, we're going to be looking at two alleles, each of them having a different potency. If the alleles are identical, which can happen, we call those homozygous. If they are non-identical, which is more typical, we call those heterozygous. The potency of the gene that is produced, or the protein, in this case maybe an enzyme or a transporter, is a function of the sum activities of the two alleles. And that's how single nucleotide polymorphisms cause changes in the DNA which affect the reading of the gene. Now, there are other mechanisms which I won't go into detail, but I want to mention them just because they're sort of background, and that is methylation. Methylation is both normal and abnormal. It's, for instance, the methylation of cytosine shuts off, silences one of the X chromosomes in females, and of course that's important, it needs to be done. It's also, methylation is a method by which the promoter region of a gene can be shut off and suppressed. Methylation can be permanent. Some methylations are quite pathological and probably responsible for most of what we call cancer. I want to give you an example of a patient case that starts to introduce some of these concepts. Patient S, this is from I think last year. He was a 28-year-old, happily married infantry soldier, 2 tours of duty, medical discharge with low back pain. He was prescribed and he self-reportedly abused hydrocodone. His wife convinced him to go see a physician and stop using the hydrocodone and get free of the dependency. He presents with flu-like symptoms, to his physician, professing addiction, requested opiate substitution. He was not physically examined, and he was given 30 milligrams of methadone. The next day, he continued to present with these flu-like symptoms, which were interpreted as a withdrawal syndrome, and he was given 40 milligrams of methadone because 30 hadn't helped. On day 3, continuing to present with what was interpreted as a withdrawal syndrome, flu-like symptoms, he was given 50 milligrams of methadone. If you are not familiar with methadone, these are not huge doses. And in fact, if it was an opiate substitution program, he would routinely be started on 30 for an opiate-dependent person. On day 4, he was found dead. Now, at the autopsy, the femoral blood methadone was 500 nanogram per mil, which is a little excessive for a person who's only been taking it for 3 days. The calculation that the medical examiner did suggested that he might have taken additional non-prescribed methadone. And the half-life of methadone, as you probably know, is about 24 hours. It's a very long-lived drug. We know the volume of distribution, we know his body weight, we knew his height, we can calculate what the amount was on board. It seemed like a lot. So was it a self-inflicted accidental death was the question. And it came to me for forensic review. Just to put you in the picture of how methadone works, if you give the same dose once a day, this is about over a week of use. Because the half-life is 24 hours and you are redosing every 24 hours, the blood level will increase daily with no increase in dose until it reaches a plateau. What's shown here with the dotted lines and the straight lines are actually the two enantiomers of methadone, the R and the S forms. The R form is the more potent. And you can see that those levels are much higher than the S form because that's the proportion in the mixture that we call methadone. So even without an increase in dose each day, his blood level would have risen. To explain, and remember, he was getting excellent results from hydrocodone. So a consideration for me was to look at his enzymes that metabolize hydrocodone and metabolize methadone. Hydrocodone is metabolized by cytochrome P452D6. That's its major route. It's also metabolized somewhat by 3A4. But the 2D6 produces from hydrocodone, produces hydromorphone, which is vastly more potent than hydrocodone. In a sense, hydrocodone is perhaps a prodrug of hydromorphone. He was getting excellent pain relief and delicious sensations from his hydrocodone. However, 2B6 is the P450 enzyme that metabolizes methadone. So we cannot look to how he reacted to methadone in order to understand what hydrocodone was doing to him. From a forensic pharmacology review, I ordered the P450 genotypes for 2D6 and 2B6. I assessed a genotype, I ordered it for his opiate receptor, the mu1 opiate receptor, which again is genetically determined as to its sensitivity. I did order the genotype coding for his catechol-methyltransferase and his monoamine oxidase, but I didn't get the MAO, so I won't discuss those here. And more importantly, maybe, I got independent forensic lab quantitation of both methadone and its metabolite, which the medical examiner had not done. He just measured the methadone. I looked at the literature for what it would possibly be, the ratio of methadone and metabolite, from dead cases and from living cases, and basically you expect a ratio of between 5 and 10 with a couple of outliers, but that's the sort of ratio of methadone to metabolite that you get. And then the results came in for subject S. And his ratio was 25.91. So he is not metabolizing his methadone. He is not making EDDP. That pretty much explains a lot. The pharmacogenetic analysis was interesting. His cytochrome 2, P452D6 was normal. I will explain to you what star 1 and star 2 means, because I think you need to know. It's not all that frightening to understand. That's his genotype, which produces a normal metabolizer phenotype. These are essentially what a wild-type phenotype is. And although it's called normal, they are actually a minority in the population. The normal phenotype is also often referred to as extensive. They are the same thing. And they are different from the ultra-fast, which have multiple copies of these alleles. His opiate receptor sensitivity, he is high opiate receptor sensitivity. He will experience exquisite effects from opiates. There are people who don't, and it lies at the level of the mu1 opiate receptor. You'll notice that he was a non-expressor of cytochrome P453A5. Star 3 is actually an absence of function entirely. That's not unusual in Caucasians. It's more or less the normal condition. But 3A4 will take care of most of those metabolisms, and he is wild type on 3A4. He's normal. This is really the key to why he died. He is an intermediate metabolizer for methadone, and in the words of the lab reporting this, methadone levels may increase by up to 75%. There's increased risk of respiratory depression, meiosis, somnolence, QTC prolongation, and nausea. And of course, the dose was being increased each time. So, does anyone want to hazard a guess about those flu-like withdrawal syndrome symptoms? What was wrong with him? He had flu. It wasn't a withdrawal syndrome. We shouldn't laugh, really. He's dead. The OPRM1 gene is interesting for a number of reasons, not just in his case. There are many, many polymorphisms, but the most common non-synonymous polymorphism is an aspartate asparagine transposition in A118G. The G allele is associated with higher pain sensitivity. The homozygous GGs require higher opiate doses to relieve pain. The homozygous AAs report less pain from illness, and particularly from diabetic foot ulcers. And G carriers have a lower naltrexone relapse rate when naltrexone is used in alcohol treatment. So there are good reasons why a prescriber might want to know this information. And there are, I think, few excuses for not knowing it if the patient's going to die. The phenotype is the activity of the gene itself, of the gene protein itself, but the genotype that is coding for it sets the baseline function. And the phenotype is modified by the environment or by interactions, but not always, because an inactive gene is not inducible. I give you the example of the 3A4. There are drugs that will be metabolized through 3A4, and they're not going to be metabolized. An inhibitor or inducer of 3A5, excuse me, is not going to change things because the gene, the enzyme is not there. An example of other 2B6 substrates, methadone was metabolized in that case by 2B6. I just put a few up here because they're psychiatrically relevant, but bupropion, ketamine, selegiline, methadone, those are substrates for 2B6. Substrates compete with each other for the 2B6. So if you do have someone on methadone and you give them bupropion, you can expect the methadone levels to rise. Inhibitors may be not prescribed by the psychiatrist, but apparently clopidogrel is being quite widely used now as prophylaxis against stroke and prophylaxis against heart attacks. Those inhibit 2B6, which again would cause the levels of bupropion or methadone or selegiline to rise. Inducers will drive the enzyme activity of the phenotype into high gear, and they will reduce the level of the drug. So the phenotype is subject to modification, but the base activity of the phenotype is set by the genes. There is an environmental effect that modifies the gene. Now, I want to move on to a slightly different subject, which is the effect of stress on genetic predispositions. And I want to introduce an idea, actually from my high school physics class, because I don't think that stress is important. I don't think it's important at all. I think that what's important is the strain that results from the stress. And I remember an experiment. It was called the measurement of Young's modulus. Does anyone remember that? You had a metal rod with weights on the end of it, and it bends, and you measure with a ruler how much the metal has bent. And some metals are soft and they bend a lot. Brass, copper, some steel, they don't bend much, you add more weight. What happens is that the metal bends over its elastic range as stress is added to it. And then it reaches a point called the elastic limit when it will not come back to its original position. It has been deformed. There is a further point, if you continue adding weights, where it fractures. It never comes back. It's broken. And I think what we're really looking at is in the effect of stress on underlying psychological disorders is really strain. It's the way the body acts, is acted upon that is important. You might think of it as resilience, but the actual stress itself, I think, is overemphasized. There are a number of things that we know are altered by stress or strain. Telomeres, I mentioned earlier, there's a dose-dependent association of telomere shortening and the severity of depression and early mortality. I don't know if that's cause or effect. Dr. Ordway there will know the answer if you have any questions about that. Monoamine oxidase A is associated with violent and delinquent behavior in response to punishment and stress of punishment as a function of a polymorphism in the upstream variable number of tandem repeats area, which is in the promoter region of the monoamine oxidase. Kids that are treated roughly, that have this variant, become delinquent, but they don't become delinquent if they're not treated roughly. The 5-HT transporter linked polymorphic region is one that has been most associated in research with depression, and I want to talk about that for a bit. Another piece of terminology that you will see in the literature. I don't know how this started, but apparently, I think computer programmers got hold of the genes before their identity was known, so that some of them carry ridiculous names. What you or I would call the SERT, or the 5-HT transporter, is in the literature called the SLC6A4 gene, standing for solute carrier family 6, type A4. Dopamine is A3, and norepinephrine is A2. I'm going to call it the 5-HT transporter, because I know what that means. And the 5-HT transporter, the gene for it, occurs on chromosome 17 on the Q arm at position 11.1 through 12. It has a promoter region, which is subject to insertions and deletions. That's usually abbreviated from a terminology point of view as the indel region, insertion deletion. The indel promoter polymorphism is what we'll be looking at here. There is also a polymorphism that's important psychiatrically in the second intron of the variable number of tandem repeats area. Now this is all in the promoter region. This is not the serotonin gene, the serotonin transporter gene, it's the promoter region for the gene. The gene reading starts here at the transcriptional initiation codon. This is essentially the gene. But the variations that occur in the reading of the gene occur because of changes in the promoter region. The one that is most associated with depression, which is what I want to talk about next as an underlying condition which might be subject to treatment, is because it is associated with changes in this promoter region, the 5-HTT-LPR modification. And that's from work that was done by Caspi et al. I think he was at the MRC when that was begun. I'll explain that now. But in essence, because of the deletion in the promoter region, you can think of the serotonin transporter gene as occurring in two types. One is called short, one is called long. It's not actually the gene that's short. What's short is the variable number of tandem deletion regions. The gene itself is the same length, but we call them short and long for this reason. The short allele has been associated with a number of things, both in animals and men. It's associated with behavioral anxiety and harm avoidance. It's associated with increased endocrine reactivity to threatening stimuli, higher brain activation, and worse distress under conditions of what I would call guilt, feeling guilt. And it's most importantly associated with the development of depression and suicidality in response to stress. And that's what I'll talk about next. And there is an incidental difference in that there is a differential response in short versus long in the response to SSRIs versus tricyclics. Now, Avshalom Caspi and Terry Moffat, I think they are in North Carolina now. The original research, I think he was at the Medical Research Council in London, looked at what's called the Dunedin Multidisciplinary Health and Development Study birth cohort of 1,037 children assessed at ages 3, 5, 7, 9, 11, 13, 15, 18, 21, and the cohort was virtually intact at age 26. It's an excellent prospective study. This is incidentally not Dunedin in Scotland, it's the other Dunedin in New Zealand. They used the DSM-4 interview schedule to yield a quantitative measure of depressive symptoms and categorical diagnosis of the depressive episode. At the end, 3% of the subjects reported past year suicide attempts or recurrent thoughts. Not unusual for a population that size. And they also collected informant responses from significant others and confidants, obviously when the children were 3, 5, and 7, but they continued to do it throughout the study. It's a very, very good study. They stratified the population on the basis of short and long 5-HTT-LPR genotypes. They found that 14% were homozygous shorts, 31% were homozygous longs, and 51% were heterozygous, both short and long. And that's almost Mendelian. There were no sex differences in the genotype frequency. As to the stress that they were under, which included assessment of employment, financial, housing, health, and relationship, etc., divorces, deaths, 30% of these subjects experienced no stressful events. I don't know anyone like that, but there were a lot in this group. 25% experienced 1, 20% experienced 2, 11% experienced 3, and 15% experienced 4 stressful events. There was no relationship between the transporter genotype and the number of stressful events. When looking at the childhood maltreatment group, we see the first indication of the significance of the short versus long serotonin transporter genotype. For the case of no maltreatment, the probability of major depression episodes was the same in short and long genotypes. In severe maltreatment, it did not seem to increase the probability of major depression in homozygous long genotypes. But the short homozygotes were more subject. They had a greater probability of depressive episodes under severe maltreatment. The short-long heterozygotes were intermediate. When you look at the lifetime issue of stressful events, you get a very similar pattern in that self-reported depression symptoms correlated with the number of life stress events show that, again, the long serotonin transporter seems to be relatively unaffected by the number of stressful life events in terms of depression symptoms. The shorts are most affected by the number of stressful life events, and the heterozygotes with one short and one long allele are intermediate. There is an area at the bottom of this curve that you tend to think is just a quirk of statistics, but in fact, when you look at actual suicide attempts or suicide ideations, that is a region that tells us a great deal. And what this is showing us is that for the shorts, 2 copies of the short allele, the probability of suicidal ideation and suicide attempts is highest for the number of stressful life events. They are vulnerable to suicide and depression in a way that the longs are not. And the heterozygotes are intermediate. I think the most interesting part, though, is at the bottom of the curve. Although the longs seem to be immune to the effects of stress on depression or suicide, in the case of the shorts who did not have any life stressful events, their risk of suicidal ideation and suicide attempt is much lower than the longs. In other words, a protective, non-stressful life protects against suicide, depression, protects against it. When compared with what I'm thinking of as the wild type now, the long. But they are clearly more vulnerable to the development of depression and suicidality, the shorts. Now that was uncategorized as to the type of depression, that study. More recently, Benedetti, published in 2014, looked at the same thing in bipolar disorder. And he found the same kind of relationship. Not precisely the same, but for a very low level of stressors in the bipolars, they have a much lower incidence of suicide attempts, whereas the longs, again, seem to be relatively immune in response to stress. So there is perhaps a protective or a damaging effect, depending on one's vulnerability upon one's serotonin transporter gene. Benedetti also looked at a brain scan area to see if there was a correlation to this increased probability of attempting suicide and early stress. And he found that the correlation occurs in Brodmann area 46, the right inferior middle frontal gyrus, which may then be either cause or effect, but certainly may be responsible for this phenomenon. As to the geographic variance in 5-HTT-LPR frequency for the short and the long, varies widely, but in all of my research that I've been doing, I find that it is very difficult to define an ethnicity, and it's becoming even more difficult now. There's more variation amongst the different African ethnicities than there is between the African and the European. Ethnicity doesn't mean anything when you're looking at it at this level of genetics. You can talk about geographic origin, and that's what this attempted to do, but it really only means things for populations that don't migrate, like the Japanese or the Korean. So I don't know that it's very helpful, but the percentage of shorts in the African American population is about 17%. In Japanese, it's about 80%, with variation of other races in between, if you can call it that. There is, however, a significance from a therapeutic point of view. 2 meta-analyses have shown that shorts are poor responders to SSRIs. They are good responders to tricyclics. And the opposite seems to be true amongst the long serotonin transporter. SSRIs they respond to well, and tricyclics they respond to poorly. There was a German study that showed that the shorts who respond poorly actually respond well if you augment that with lithium. I don't know if that only applies to Germans. But what's missing from these studies, which seem so clean and so clear, is that the P450 genotype was not assessed. So that we do not know how they were handling the antidepressant drug as a function of their response in treatment of their depression. That needs to be correlated with these findings. Moving on to a related clinical study, forensic consult. This was the case of a male, white, age 19, apparently in the autistic spectrum, apparently ADHD. He had high IQ, he had no antisocial or criminal history. He was introverted, he was shy, he was enthusiastic about computers and about programming. He was prescribed Adderall, 10 milligram 3 times a day, and methamphetamine, 5 milligram 3 times a day. He became more anxious and more depressed, and he presented for additional treatment. His doctor put him on Prozac, 20 milligrams a day, and clonazepam, 0.5 milligrams. Some weeks later, he was arrested for fire setting in public places. There's a whole series of them before they stopped him. And a forensic consult was asked for. This is what the lab reported to me. His 2D6 genotype is a 4-4. That's completely inactive. He's a poor metabolizer. His 5-HT transporter is a short-long. His HTR2A, that's the serotonin 2A receptor, was decreased activity. The narrative that comes from the lab is that he can metabolize neither methamphetamine nor amphetamine, and as you know, methamphetamine is converted by 2D6 into amphetamine, and amphetamine is further metabolized by 2D6. So he can't metabolize it. They parsimoniously said that dextroamphetamine levels may increase by more than 200%. So he was toxic, with a risk of agitation and so on. He could have been prescribed safely Ritalin, but he wasn't. 2D6 is also the enzyme system responsible for fluoxetine metabolism. Fluoxetine is metabolized into its long-lasting hydroxy metabolite, which has an enormous duration of effect, and is probably responsible for nearly all of the therapeutic effect, where there is one. He can't metabolize it. He cannot produce the active metabolite. All he's going to get is adverse effects. Increased risk of anxiety, anorexia, insomnia. This was adding to his problems. Added to which, he has a decreased serotonin 2A receptor activity, and he's an intermediate serotonin transporter. there were alternative treatments he could have been given, but this was clearly the wrong one based on his genotype. Now, when we speak of a normal 2d6 in a population, we're talking of the wild type, but it's actually quite rare, the normal. 35% of the population are carriers of a non-functional 2d6 allele. 7% have the ultra-rapid phenotype. 7% have the immediate phenotype. So there isn't such a thing as a normal person as regards 2d6. I think it's something that you need to know. And looking at the population distribution, this is an Indian study, frankly tells us nothing. Before genotype testing became available, and I use a Q-tip, a swab, to take buccal sample and send that to the lab. But before that was available, I used to use dextromethorphan. You give the person 30 milligrams of dextromethorphan, and you collect their urine for 24 hours. You actually don't have to do it for 24 hours, but, you know, it's easy that way. And then you take a sample of the urine, and you measure the dextromethorphan-dextrorphan ratio. If it's greater than 0.3, you have a poor metabolizer. You can also use dibrizoquin. Historically, what we now call cytochrome P452D6 used to be called, when I was at school, dibrizoquin hydroxylase, but now it has a fancy letter number name. Or you could use tramadol, because tramadol is converted to O-desmethyl tramadol by 2D6. O-desmethyl tramadol is the metabolite that is responsible for much of the psychiatric adverse effects of tramadol. So you might want to know that if you're giving tramadol other than as a test. At this point, I wanted to tell you where these designations of high activity, low activity, no activity come from. I'll try not to bog you down too much. But the alleles that have normal function, there are about 10 of them, but 3 of them only are common. These are normal function alleles, and of course, the so-called wild types. If you have 2 of those, then you are normal. The reduced function alleles, there are lots, more than 12. We call these, it's okay to call these star 9 or type 9 if you find yourself in conversation with someone. But the majority of the 2d6 alleles are non-functional. And when you see an allele described as star 5, that actually means that there is no allele. It's deleted. So this being the possibility that the patient may have, the lab will assign an activity value of 0.5 or 1 to the non-functional, reduced functional, and wild types. You have 2 copies. These are both measured, 2 alleles. An activity score for a person who is star 1, star 2 would, for instance, be 1 plus 1, which is an activity of 2. An activity score for, let's say, someone with a star 2, star 10 would be a 1 plus 0.5, a score of 1.5, and so on. Now, you may also hear from the lab that there are additional copy numbers. This is not uncommon at all. And when you do, you will have ultra-rapid metabolizers. Lest you think 2d6 is not all that important, this is a list of 2d6 substrates. Notice the psychiatric drugs in there. Since these are all substrates, they will compete for 2d6. If you're giving more than one of these compounds, you're affecting the level of the other. You're raising it. The other consideration is that there are drugs that inhibit 2d6. Lest you think that these are rare, they're not. And many of them are over the counter. As to drugs that induce, or chemicals that induce 2d6, really nothing much, except, of course, steroids. And I want to mention just the other substrate, the other P450s before I move on to something more on a different subject. But the P451A2 is responsible for a great deal of the antidepressant and antipsychotic metabolism. Inhibitors and inducers are common. Tobacco is an inducer. If you get someone that is on olanzapine who is a cigarette smoker and you discontinue their cigarettes, you are going to downregulate their 1A2 and their level is going to rise. Char-grilled meat is also an inducer. And it's the smoke, not the meat. Also, in the tobacco, it's apparently the smoke, not the nicotine. Likewise, 2C19 is not harmless. These are diazepam, amitriptyline, citalopram, imipramine, all metabolized through it. Inhibitors include very common compounds, including birth control pills. And the inducers, some of them are over-the-counter, such as St. John's wort. So you need to be alert for these things when you're prescribing any of these psychiatric drugs. As to the 2C19, this was 2C19, poor metabolizers, there are about 6% of Europeans, 20% of Japanese, and up to 20% of Africans that are poor metabolizers, which means that they really can't metabolize. So you would need to know that if you're prescribing one of these drugs. But within those populations, there is enormous heterogeneous variability. So you can't simply say, well, it's a European, so he's probably not a poor metabolizer. For instance, in the Polynesian population who are poor metabolizers, that ranges from 38 to 79%, depending on the region within Polynesia. So again, it's useless to argue or to hope to gain anything from an understanding of what a person's race is. You have to measure it. The significance of that for 2C19, I just give one example here. Imipramine is metabolized to desipramine by 2C19. At least this is the major route. Desipramine, of course, is another antidepressant, another tricyclic. The significance is that it's a completely different compound. Imipramine is most active at the serotonin transporter, and it has not a great deal of activity at the norepinephrine transporter. It doesn't affect the dopamine transporter at all. But it has high activity at the muscarinic acetylcholine receptor. Yes. In contrast, desipramine is most potent at the norepinephrine transporter and at the 5-HT2A receptor. So you will get different pharmacological profiles depending on the 2C19 activity of the person that you are prescribing imipramine to, for good reason. I mentioned 3A4, 3A5. 3A5, as I mentioned earlier, is it's kind of rare in the European population, but approximately half of the drugs in clinical use are acted upon by 3A4. 3A4 is also the P450 enzyme that is inhibited by dihydrobergamotin, which comes from grapefruit, and some other citrus fruits, including bergamot. I'm not going to tell you much about permeability glycoprotein, because we're running low on time, except to say that it is terribly important. This is the transporter that transports things out of the brain. Substrates are, of course, citalopram, paroxetine, but not fluoxetine. Amitriptyline is transported, trimipramine, venlafaxine, doxepin. Brain levels can be affected by something that interacts with it or inhibits it. The most common ones that do are erythromycin, probably prescribed by someone else, and verapamil. You can take a drug such as loperamide, which is used for traveler's diarrhea, which is a potent opiate in vitro, but seems to have no effect on the brain in man, or very little. But that's because it is being pumped out of the brain by permeability glycoprotein. If you inhibit permeability glycoprotein with verapamil, loperamide has profound effects on the brain, including respiratory depression, sedation. And I won't go on any further. Let me briefly conclude with some forensic information that is messy, which is more like the real world. We have here a case of subject T, a bouncy little boy. Does he look in any way abnormal to any of you? Do you see any unusual things about him? Possibly foreshortened arms? Good observation. At age 19 months, his behavior was intolerable. He was put on thioridazine for pathological crying, and it did not improve. At age 3 years, he was diagnosed with hyperactivity and adjustment disorder. By age 3 years and 7 months, his behavior was described as intolerable in the records. He was put on imipramine. And at this point, his mother described he just went bonkers. He threw a brick through her car window, and his bed was actually, it had crib bars around it. He broke the crib bars. He was completely out of control. He was taken into inpatient for a year, and it was noted in regard to his response to imipramine, never to be given an antidepressant. He continued explosive behavior problems, was started on Tegretol, which was ineffective, then lithium, which was ineffective. Clonazepam was ineffective. At age 7 years, 10 months, he was restarted on thioridazine and lithium and Depakote. At age 10 years, 10 months, he was readmitted again as an inpatient out of control behaviorally. And he was institutionalized until he reached maturity at age 19. One thing that was noted when he was institutionalized at age 14 was that he had gynecomastia, that he was obese, he had a small scrotum. They did not measure his prolactin. He was released at age 19, as I said, and he discontinued his thioridazine. And over the next 24 months, his behavior progressively went out of control. He became violent, many antisocial acts, committed 5 burglaries, 17 auto break-ins. He was drunk and disorderly, shoplifting, arrested for assault and battery numerous times, public drunk, forgery, counterfeiting, and ultimately this ended with him killing 2 people in their beds with a hammer, at which point a forensic consult is requested. Does anyone know what we're seeing here? No? Hypogonadism, foreshortened fingers, female pattern adiposity, obesity, this hadn't been noticed before. Now, typically that is nowadays diagnosed by genetic analysis of chromosome 15. That hasn't been done, but on clinical grounds, that's what you have. And of course, he would have cognitive disabilities and behavior problems, incomplete sexual development, chronic hunger. As part of my consultation, I requested a microarray DNA analysis by Dr. Jack Rary over in pediatrics and Dr. Natalie Burke, my colleagues in this study. And I did a P450 genotype analysis through Genelex and a clinical examination. And what we find is that he has a 22q11 deletion. Chromosome 22 on the Q arm is missing 91,000 base pairs. This is the chromosome that contains the 2D6 and the catechol methyltransferase genes, but they actually were not in the deleted region. What was in the deleted region was the gene coding for proline dehydrogenase and a big portion of the DeGeorge critical region 5, but not all of it. Now, Is anyone familiar with DeGeorge syndrome? When complete, when the whole piece is missing, it's very obvious. This is developmental malformation, craniofacial anomalies, cardiac problems, but he's missing a piece of it, not all of it. And so we took his blood, and indeed he has hyperprolinemia, confirming the lack of proline dehydrogenase, which the genetic studies had identified at the level of the gene. The P450 genotype showed that he is a poor metabolizer of 2C19, and he is an intermediate serotonin transporter. So, 22q11 is associated with anxiety, depression, and he needed antidepressant treatments and behavior treatments because he had 22q11, but it wasn't identified. We had the same impulsivity, depression, anxiety resulting from Prader-Willi syndrome. He can't metabolize imipramine. And remember, what set the course of his treatment in childhood was his aberrant reaction, which clearly, in retrospect, was a toxic reaction to imipramine. Remember its effect on the muscarinic cholinergic receptor that I showed you earlier? Very potent. But he could safely have been given an SSRI because he's a short, long, heterozygote 5-HT transporter. And it follows that the thioridazine was really not appropriate treatment. There were other things he could have been given. From a clinical pharmacology point of view, abruptly discontinuing thioridazine in a non-psychotic individual was probably responsible for the behavior that resulted. And that, I think, concludes this talk. I have several references on here that are for you to read. These two books I recommend strongly. Mrazek's will give you a much more detailed overview of psychiatric pharmacogenetics than I can barely touch on here. And that is, less detail is found in the drug interaction book by Wynne, but he addresses the drug-drug interactions more clearly. I'm not going to talk about the monoamine oxidase. Any questions?
I'm curious to know the result of the first case, the legal case that you described, and I'm thinking as a clinician, am I supposed to get a genetic analysis on everybody before I can prescribe drugs, including opiates?
I had a discussion about that with Tom Schacht, who told me that the tonometry test that optometrists do with the puff of air on the eye, which is now standard of care, was something that was imposed on the profession by a judge in Wisconsin. Because glaucoma had developed, a very simple test had not identified it. The optometrist was sued. He claimed that he was following the standard of care, and the judge, from the bench, said that's not good enough. And now, of course, we all get the little puff of air when we go to the optometrist. So I hope it doesn't come to that. But there is a lag between what is possible and what is done. I think it behooves us all to try and stay ahead of the curve rather than being told by a judge in Wisconsin what the new standard of care is henceforth going to be.
So I'm still interested, what was the result of the court case in terms of the physician's behavior?
He was not sued. Or if he was, I don't know about it. I was consulted more on the criminal activity of the youth.
The child that was getting the amphetamine, which was 3 times a day, 10 milligrams dextroamphetamine.
Plus methamphetamine.
Plus methamphetamine.
And he can't metabolize.
Plus an SSRI.
That he can't metabolize.
That he can't metabolize. But to me, the worst of that is, of course, amphetamine, besides being a dopamine releaser, It also releases serotonin,
Mhm.
and you're adding on a serotonin uptake inhibitor. Plus, amphetamine is an MAO inhibitor.
Yep.
So that's a contraindication. Those are contraindicated.
I'm afraid it's very common.
I would expect bizarre behavior out of people who are treated that way.
This is a forensic case. Yeah.
All right. So if there are no other questions, thanks for everybody for coming. Make sure to turn in your forms.